Good afternoon, everyone. This is actually the most simple and straightforward case for the day, but I hope it will generate your interest and relatability in the patients that you see and handle. So we have here an elderly, actually foreigner when we saw the patient, but he has been a resident in the Philippines for more than 2 decades. And recent workup showed pancreatic and hepatic masses per abdominal CT, for which metastatic cancer was presumed. So the impression of the primary surgical service was more of pancreatic cancer. He underwent a PCI more than a decade ago, so that is his significant comorbid, being a coronary artery disease patient. And he came in with the chief complaint of vomiting. There was no fever. He had been anorexic, so he was actually at the ER very weak and dehydrated. And the complaint was vague chest and upper abdominal pain. So, as mentioned, being drowsy and weak, he, however, had normotensive and tachycardic, though, and on O2 support of about 2 liters per minute via nasal cannula and was afebrile. However, what was very significant upon admission was the very high WBC count of 44.6, neutrophilic predominant. The hemoglobin was 9.6 with normal platelet and a baseline creatinine of 2. That's in milligrams per DL. There was also hypokalemia and high level of calcium, and these were also medically managed. The chest x-ray showed bilateral pneumonia. So with this case scenario, my question would be, would you start an antifungal? It's just a yes or no question. I I don't know what the smiles of some of the audience mean. Is this a similar case scenario where you have to decide at the ER level? Okay, so we have a resounding no. So what happened was the impression at the ER was intra-abdominal infection, mainly because there was some ascites on physical examination and, as mentioned, a vague abdominal pain. And then cultures were taken from blood, sputum, and urine. And the primary service did agree with you and started on antibiotics. So there was an initial start from the IM service for piperacillin tazobactam. And I put there in italics levofloxacin and metronidazole because I'm sure that the IDs in the room will react to that with the redundancy of the regimen. The surgical service added the antibiotics. So to keep the good relationship, all antibiotics were there at the ER level. So on the first hospital day, this was the first time the patient registered a fever. The procalcitonin was taken on admission, but the results came out the day after, which was high at 8.8. So patient was generally weak and status quo for the next 48 hours, but on the third hospital day, the patient developed hypotension necessitating norepinephrine. There was cautious fluid resuscitation because he was beginning to have ascites, and vasopressin was also added thereafter. He, however, had dyspnea, although it was attributed perhaps to more of fluid overload with the fluid resuscitation, but he got intubated with ventilatory support. So sorry for pushing the button, but now the patient is in septic shock. So I wondered if you were the managing physician at the ER, would you now start? I said ER because I don't know if you are able to relate with a lack of rooms post-COVID with a very thin nursing population. So they stay at the ER for a couple of days before getting a room accommodation. So this is not a resounding 100%, but 8 out of 10 would not start an antifungal. So let's see what happened. At 72 hours from admission, so I think you would agree, consideration of something nosocomial, blood cultures were negative, but the urine culture, that very little pyuria that you see in UA, and the patient looks septic, so the culture was sent. So less than 10,000 CFU with yeast cells preliminary. The sputum culture, the expectoration definitely was not good. This was prior to intubation. And you have there the gram stain of 0 to 1 WBC and rare gram-positive cocci in pairs. After intubation, an endotracheal aspirate specimen was sent, and this time, it was gram-positive bacilli with few budding yeast cells. However, the X-ray at this time now showed resolving bilateral pneumonia and or congestion. I also don't know in your respective countries if this kind of reading is a bit common, wherein the final decision is really up to you as the patient looking at as the physician rather, looking at the patient. So now my next question is, with the preliminary respiratory and urine culture results, would you now start an antifungal? Nobody wants to answer now? Oh, it's still a no. But the percentage of people saying no is a bit decreasing. So that's 7.7 out of 10. So from 100% at the ER, and then at 72 hours, 8 out of 10. Now it's 8 out of 10 also. So I looked into some of the later guidelines or consensus statements of looking at how to manage non-transplant, that was the case, the first case earlier, ICU patient, non-neutropenic for possible candidemia. And I don't know also in your respective institutions if you're able to relate to this, but I looked at and did a look back that the primary impression was abdominal infection. And so the algorithm there states is invasive candidiasis more common than candidemia. And then the molecular tests started coming out and the fungal biomarkers. And we had a good discussion earlier from Dr. Lee. But unfortunately, especially in the area where I practice, we don't really have those biomarkers and elaborate molecular tests. So I got stumped from the first arrow. So with that, what happened was, eventually going back to the patient at 72 hours from admission, the blood cultures really first set taken at the ER prior to any antimicrobials turned out to be negative. The urine culture grew, as mentioned, less than 10,000 of Candida tropicalis. And then, I'm sure you'd remember Dr. Tan's lecture earlier on how to handle respiratory isolation of Candida, but both the sputum and the endotracheal aspirate grew Candida glabrata. However, as mentioned, the chest x-ray was actually improving. I don't have the films right now. But my next question to the group is, with the respiratory and urine culture results, they are different species of Candida, would you now start an antifungal? There was a discussion earlier about Candida colonization, which I wanted to trigger a discussion with this case. So the answer is majority would still be a no. That's 7 out of 10. So if we look into known risk factors in the literature, I think that our patient would somehow get some check marks in this rundown. For example, the patient is presumed malignancy. Actually, part of the plans was getting a tissue diagnosis, but he was found to be unstable for that. And then for number 2, acquisition of Candida colonization, I don't think it's too long for the broad spectrum antibiotics, and he was really meant for an ICU admission. But perhaps the tick mark there on colonization would be something that I would like to ask your thoughts about later. And for violation of anatomic barriers, he did not really undergo any abdominal surgery. And if you're wondering what happened to his diet, because he was having this abdominal pain, he was put on NPO by the surgical service for quite a long time. So it was around 7 to 10 days without any parenteral nutrition, but just the D5 containing fluids. So on the 6th hospital day, there was progression of the AKI, and this time this needed hemodialysis. So an IJ catheter was inserted, and the third port was actually used as IV access. Again, I was just curious if you do this in your respective institutions, if there's really no peripheral access, and we insert a triple lumen IJ cath and use that for the IV medications. So this time, the procalcitonin was repeated. It was relatively on the same range. No antifungal was started, but the antibiotics were shifted to meropenem and vancomycin. There was some form of stabilization in the sense that the pressors were now on the tapering side and patient was afebrile. And I just wanted to add to the fact that the patient was actually had a verbal A&D, allow natural death directive. So I think that it somehow played some role on the timing or the aggressiveness of the diagnostics that we took from this point on. So anyway, with the new events in the course, entering second week of admission or hospitalization, again, there was new onset of hypotension. The norepinephrine was never really discontinued, especially during dialysis sessions. You would have fluctuating blood pressure, but it was deemed on a very low side. In fact, there was consideration of CIRSE, the critical illness adrenal insufficiency. So an early morning cortisol was taken, which was interpreted as a good enough response from this patient. And as I've mentioned, he was put on NPO for a long time. So we mentioned about candida scoring having parenteral nutrition as a risk factor. So it wasn't really a factor for the first 2 weeks of admission. However, if you look at the CBC, the leukocytosis persisted. And part of the impression of the service was that this may be due to the underlying malignancy rather than an infection that was not being addressed. However, there was drop in the hemoglobin, for which tumoral bleed was also considered. And at day 6 of meropenem and vancomycin, you have there an uptake of the procalcitonin at 15. Maybe the other issue here is that is procalcitonin really a useful marker if we are in the context of fungal infections? No antifungal was done. However, the main event on this day was that there was massive upper GI bleeding, fresh blood, draining from the NGT, totaling to 1 liter in just a few hours. So the new problem list at this time was more of non-infectious. We assessed the patient to have more of hypovolemia from this blood loss, for which blood transfusion was done. And the pulmo service was actually considering pulmonary embolism at this time because aside from being an immobilized patient with an underlying malignancy, there were episodes of desaturation, but the chest x-ray did not match. So a venous duplex was ordered, and true enough, a proximal DVT, which was partially occlusive, was seen. That is despite the patient being on DVT prophylaxis from the time of admission. So the focus at this time was more on the non-infectious. You couldn't treat the DVT, and then you just have to address the GI bleeding. However, looking into the other forms of differentials for the hypotension, and you have the rising procalcitonin also, the repeat cultures were done, both from peripheral and the IJ cath, but still no antifungal was started. So on the 16th hospital day, that would be at 72 hours of incubation, that's when we had a gram-positive budding yeast cells through the IJ catheter. So at this time, definitely, I would not ask if you will start an antifungal or not. So my question will be, what will you start for this patient? No antifungal exposure since admission. Would you go for fluconazole, and echinocandin, or amphotericin? So I thought we'd get 100% on that. So 8 out of 10 would start an echinocandin. So we don't have, Dr. Tan, we don't have caspofungin in our country. When it was pulled out, correct me if I'm wrong, I don't think it has made a return. We do have anidulafungin and micafungin. So this patient was given anidulafungin. The final blood culture results revealed gram-positive budding yeast cells. That was Candida tropicalis. So if I may do a look back, the respiratory isolation, this is what I would want to ask our panel of experts here in the front, what you thought about that, having a different species of Candida as respiratory isolation, and then you had the tropicalis growing out from the urine, and now you have the what is seemingly a catheter-related bloodstream infection that is growing Candida tropicalis sensitive to fluconazole. So the issue is central line removal, but I will not dwell on that because at this time, patient was really progressively deteriorating. And as I mentioned, there was an A&D directive, so we kind of modified also the way how aggressive we were. Although we actually discussed with the family that ideally the catheter should really be removed. So what happened to the patient eventually expired. The first cause of death was, of course, the Candida sepsis, but we didn't have any other access. So unfortunately, the IJ catheter stayed there. Despite 10 days of anidula fungin, we were able to get a repeat blood culture that still grew the same fungus. So the key takeaways therefore, for this very simple case of invasive candidiasis in the ICU would be a look back at antifungal strategy approaches. I was wondering if we started him early on, if that would have been prevented. But if we, this is once again alluding to the European consensus statements that prophylaxis, and this was mentioned also by Dr. Tan's lecture in the management of IFIs, that there is a recommendation against routine and universal administration of prophylaxis in critically ill patients. So with preemptive, although it becomes a default in our setting, because as I've mentioned, we don't have those early biomarkers that supposedly trigger workup and an early start of antifungal therapy. So we are down to empiric. It might be considered only in patients with septic shock and multi-organ failure and more than one extradigestive site, which was actually what we had in our patient. So with that, the other recommendations would be not to start empiric antifungal therapy in patients without septic shock and multi-organ failure. And then another highlight of respiratory isolation of Candida, not a sole parameter to initiate treatment. And this last statement would, of course, be a segue to a very special session that we will have on the last day, which should be promotion of antifungal stewardship programs in order to limit the use of empiric therapy. The other key takeaway here is that you might be wondering why I never mentioned about the local resistance patterns. It was not data available at that time when we were seeing the patient, which also reflects, once again, the last bullet about antifungal stewardship, always starting with robust data of incidence rates and surveillance in the institutions where we practice. So with that, I'd like to thank you for your attention.